And today I will be discussing obsessive-compulsive disorder, or OCD. So just a little overview of what we'll be discussing within our 5-minute crash course of OCD. First, I'll go over the definition of OCD, what it is, what it's not. Then we'll talk about the symptomology via the DSM-V diagnosis. We'll discuss the physiology, the specific parts of the brain that contribute to this disorder, and possible treatment as well. So what exactly is OCD? It stands for Obsessive-Compulsive Disorder. It's not only a type of disorder underneath anxiety disorders, but it's also its own subdivision underneath anxiety disorders. And that subdivision includes body dysmorphic, hoarding, trichotillomania, excoriation, and other disorders as well. So the two main components of OCD are obviously in its name, but obsessions and compulsions. Obsessions consist of recurrent persistent thoughts, urges, and images that are very intrusive and unwanted and move them to have to participate in compulsions, which are identified as unwelcome, unwanted, repetitive behaviors, or mental behaviors even, that the individual feels they have to perform in order to avoid or prevent, suppress the obsessions and the resulting consequences that would result if they don't participate in these compulsions. There is a difference between OCD, the disorder, and people who are just very organized or very strict with their behaviors. So for instance, a woman who washes her hands before every single meal without failing, that wouldn't be OCD, that would just be her strict cleanliness, because it's not unwanted. She still wants to clean her hands. It's not causing her any impairment. It's not causing her to lack or in functioning in her regular life. So an example of OCD for this would be a man who has to wash his hands 100 times exactly every day until they are red and raw. Alright, so the DSM-V diagnosis for OCD, it involves there has to be either obsessions or compulsions or both acting up in the individual's life. Obsessions would be pretty much the definitions we already went over. 3 other criteria. Obsessions and compulsions have to be time-consuming, they have to be impairing, they have to be taking up parts of their life and affecting them in a significant way. Symptoms also must be not attributable to any other disorder, as well as the disturbance can't be better explained by any other disorder. Further specifications for OCD include with good or fair insight, which is defined by the individual's ability to recognize that these aren't realistic, their behaviors aren't realistic. With poor insight would be defined as they think that their beliefs are probably true, they just aren't quite sure. With absent insight would be they absolutely believe it without a doubt. And there is a specification for tic-related with a history of tic disorder in the past or a current history. So the physiology. So physical factors aren't always the only thing at play, especially in OCD. Temperamental, environmental, social factors are always at play. There is also a strong genetic component for OCD. Individuals who have a family history of OCD are 2 times as likely to develop it, and those with immediate family with OCD are 10 times more likely to develop OCD. In cases of monozygotic twins, and those case studies, they found that monozygotic twins who developed OCD, their twin was 56% likely to develop 56% more likely to develop OCD themselves. Strong implications. So the pinpointed absolute cause of OCD is not has not been found, I guess, or discovered. It's really hard to pinpoint because there's, as we know, there's lots of different areas of the brain that contribute to lots of different behaviors. So pinpointing one area is very hard, and it's very hard to get actual support for these case studies. But there are strong implications that dysfunction in the orbitofrontal cortex, the anterior cingulate cortex, and the striatum are the main parts of the brain that contribute to OCD. Basal ganglia, cingulate gyrus, prefrontal cortex also contribute to dysfunctions in those parts of the brain, also contribute to OCD. So further specific physiology that contributes to OCD would be a greater activity within direct pathways between basal ganglia and the thalamus. OCD is also correlated with extremely high activity in the ACC, which we just looked at, and its relationship between the prefrontal cortex and the basal ganglia within the brain. Also within this study, it showed that the relationship between the ACC and the hypothalamus, hippocampus, and amygdala showed extremely high activity. And my point in this is also that the hypothalamus, hippocampus, and amygdala are responsible for homeostatic actions. The hippocampus is responsible for the organization of memory, and the amygdala is responsible for emotional responses. So OCD doesn't just affect, the prefrontal cortex or the frontal lobe and higher level thinking, but it also affects, homeostatic functioning, working memory functioning, and etc. It's also correlated with low levels of serotonin, which could be a result of the amygdala, hippocampus, or hypothalamus being affected as well. So overall treatment, the most effective treatment for OCD combines a regimen of all of these. So instead of just picking one, a person would go to CBT, they would have a benzodiazepine to lower the activity, and possibly, if the symptoms are severe enough, an SSRI to reduce the reuptake of serotonin to increase its effect. All right, and here are my references. Thank you for listening.